Okay, so I'm Dr. Bisi Aluko, and this is the class 2 of the menopause class teaching. In class 2, we're going to focus more now on the treatments that are available. I will, as much as possible, try to explain the treatments in a bit of a layman language and try not to use a lot of medical jargon, but just the same as we did in the first class, at the end of the second class, if there are things that was just a little over that somebody did not understand in regards to treatment, please make sure you ask me the questions to clarify. So we'll mention a few of the symptoms, but mostly we're going to discuss the different treatments that are available, or as we say it in a more umbrella way, different management, because some of them may not even be medication. Some things we may talk of things that are non-prescription medication. So generally, we'll talk about treatment, and a lot of the treatments that I'm going to talk about will be based on what is approved by the North American Menopause Society. So I follow the rule, and they're the biggest menopause society in North America, which includes Canada, US, and Mexico. I go for the conference every year, except this year because of COVID, I'm not going into the US. But it's a big organization. They have the state of the art, everything, and they have the best recommendations for menopause management. So we are now going to go into treatments that are available. So back to the house rules, we remind ourselves of confidentiality and respect for one another. It's an informal group. We can ask questions, but because we're recording, we'll keep the questions to the end of the class. So everybody jots down your questions. And as I always say, we should always remember as women that we are unique, and in our midlife and menopause journey, it's different with every woman. Okay, so it's a general rule on menopause management. The relation of menopausal management must be balanced between a person's symptoms, their personal preference, the personal and family medical history, the dose, the route, the formulation, the benefit versus the risk of whatever treatment that they're interested in. So no size fits all. It depends on each person. The general rule I will say, like I said in the summary earlier on, is we should all try and make healthy lifestyle choices. We should see our physicians regularly for preventive health checks that are appropriate for our age. We should find a healthcare professional that we can discuss our menopause-related concerns with. If you love your family physician, he or she is great in everything, but cannot address your menopause, what I tell people is, yes, keep your family physician. He can take care of everything, but try and find somebody who can understand your menopause concerns. You can come to that person, take information, take it back to your family physician, and both of you can sit together and work out what will work best for you. But don't say, because my family physician is not listening, then I'm just going to suffer it out. No. These days, we're getting more females in family in medicine generally than we used to. So lots of women out there who can understand another woman. And there are some awesome male physicians too that are very, very good with menopause-related concerns. So the first thing I'm going to talk about is weight, because that bothers a lot of women. So weight management, we'll talk about the diet first, the diet part of it. So many diets are out there. Eat this, don't eat that, don't eat that. What I have here are things that are from the North American Menopause Society Journal, the types of diet plans that have been tried and have been found to be good for menopausal and for perimenopausal and menopausal women. But the first thing I always say to anyone who asks me, what diet should I use to maintain my weight or to lose weight? Canada Food Guide. You can never fail if you use Canada Food Guide. Weight Watchers. Weight Watchers is basically almost like Canada Food Guide, except they do theirs in points, which just because human beings will like rewards and things like that. So it just makes it more effective. There are three, for someone who says, okay, I want to go on a very special diet because I need to lose, because Canada Food Guide or Weight Watchers is just helping me maintain. These are the types that have been tried and are found to help with being menopausal, because the way our metabolism works when we are peri and postmenopausal is different from the way it worked when we were in our 30s. It's different from the way the metabolism of a man's body works. So that's why some of this diet is sort of better for menopausal women. So one of them is the low-fat, low-calorie diet. The second one is high-protein diet, because we lose a lot of muscle in menopause. So we need protein to build the muscle. Then the third is the alternate day fast diet. I always kind of talk about this alternate day fast diet because it basically means I eat today, then I fast the next day. We've got to be careful if we're doing alternate day fast diet not to gluten out the day that we eat, because the natural response of the body is, okay, I'm going to fast tomorrow. So so we end up eating for the 2 days. And then people come back and say, I haven't lost anything. Yeah, you're probably not going to lose if you don't consciously tell your body and tell your brain that even though I'm going to fast tomorrow, I'm just going to eat my regular portion today. Because if we don't, the body, especially as we started, the body will just automatically want to eat for those 2 days in that 1 day. So that's one thing I always tell people to be careful about if they decide to choose that for their way of losing weight. So there are other diets. The cardiologists, they love the Mediterranean diet. It's awesome, especially for somebody who has heart disease, hypertension. It's very good. The glycemic load diet, it's good for somebody who is the diabetic, because then they can find foods that are not high in glycemic index, which are usually like the white carbohydrates, the potatoes and things like that. So those are other diets that they found to also help a little, but the first three are the main ones. But like I said, I never push any diet, because the second point, when we're planning to start a diet, ask yourself, can I maintain this eating style for long term? If you can't, then don't even start, because then we're going to yo-yo. And maintaining it means paying for it. Can I maintain all those people that drop food, already made food, and what's the name? Some diets where they already prepare your food and they bring it to your doorstep. Those things sometimes are so expensive, to be sincere, even I can't. So are those things that you're going to be able to maintain? They're out there on the TV saying you will lose weight, but can you financially afford to stay on this diet? Can I incorporate whatever diet into my lifestyle? Is it something that works with my lifestyle? If I'm going to do something where I'm measuring some containers to take to work, do I have enough time in the morning to measure my containers? If I don't, it's only going to work for 1 week and I'm going to fall off the wagon. Is it affordable for me? But I said, some of these fancy things, is it something that's within our pocket? So if we're going to choose any diet, make sure it's something we can cover. Otherwise, then let's just stick to Canada Food Guide. Okay. So average, oh, sorry, that's okay. The average daily calorie intake, it's been found to be more important in weight loss than just the diet composition. So because, as I said, we lose muscle, we need to just watch, make sure we're eating enough protein and we're not putting in too much calories into our body. Okay. The next thing after what we put in our mouth is how much we're burning it. Because as we know, weight gain, weight loss is how much am I taking in, how much am I using. What is recommended for menopausal women is 150 minutes per week of moderate intensity exercise. So no studies have shown whether if I decide to do my entire 150 in one day, that it makes a difference, or if I decide to do it in 2 days, or if I decide to break it down to 30 minutes every day for 5 days, there's no difference in the way I decide to do it. The important thing is doing 150 minutes, and it must be moderate intensity exercise. Walking my fat, chubby dog in the evening where we're barely walking, it's not counted. Or in the office, I'm always active. I walk from my office to go to the fax machine to pick up the fax or to print. No, because you're not running to the fax machine. It doesn't count. We also need to do muscle strengthening and stretching exercises. We lose muscle strength. We lose our balance. Our joints start getting tight. So those are very, very important. And then there are medications that are approved by Health Canada for weight loss. We have a pill called Contrave. It's 2 medications that have been in the market for 1 billion years that have been put together to help with weight loss. What does it do? It speaks to our brain for us to stop eating. Basically, that's what Contrave does. Then there is Xenical tablets. Xenical, basically what it does is it prevents us from absorbing oil. We'll actually see ourselves put that oil into the toilet. So if you decide, let's say you take Xenical, you go to KFC or one of these places that make all this chicken and you eat it, you'll actually see yourself poop oil. People end up with diarrhea sometimes because it just won't let your body digest that oil at all. So that's the way Xenical works. Then there is Liraglutide Injection. These 2 injections were originally diabetic medications, and they were found that people were losing weight because it tells the stomach you're full. So that way you don't eat so much. So they're all approved for weight loss. So those are medications that are available for people to use. And then we all know about surgery, all the fancy surgery, the bands and all of those that can also be done if needed for those who are really significantly overweight. The bone and dental. If we remember in our previous class, we talked about losing bone and losing our teeth. Our teeth enamel starts to wear midlife and menopausal period. It's important for us to go for regular dental exam. Good oral hygiene is important. Visit your dentist regularly. It's also important for us to get regular bone density. Our bones get thin. If we fall, we break our bones very easily. And we may think, oh, just the bone, then it gets casted. But many, many studies have shown that when we do have those major breaks, it can affect our mortality. That means it can shorten our lifespan because People break their hip, they go into the hospital, they end up developing blood clot, or they end up having a heart attack and all of those things. So if we can, we want to prevent that. Then there's another thing that people do not know, even if we don't fall, our spine, if there is severe osteoporosis, which is the severe thinning of the bone, the spine can actually start to crumble on itself. We call it compression fracture, which is almost as though you put a big weight and you're squashing the spine down, and it does give pain. So we want to prevent all of that. So it's important to have regular bone density done by the primary care physician. Then the way we can prevent this also is by taking our calcium regularly. It's recommended we take 1,200 milligrams of calcium per day. You don't have to take it all as vitamin. If you're eating, you can calculate it. You can eat your cheese, you can drink your milk and get enough calcium from it. Then vitamin D, that is important, especially for us Canadians. We do not get enough sunlight. So every woman 50 years plus in Canada should be taking 1,000 to 2,000 units per day of vitamin D to keep their bone strong. And then there are medications that doctors can prescribe if the person's bone density is actually low. There are pills, there are injections that can be prescribed to keep the bone density strong. Eyes and ears, getting regular hearing and eye exam. We talked about dryness in the eyes. We talked about reduced hearing. It's important for us to get our hearing checked. It's also important to get our eyes checked, use eye drops if necessary, if there is dryness in the eye. Then fertility. Many women think, okay, I'm in perimenopause. I'm in my 40s, so I can't get pregnant. Yes, we can. Up to a year after the final menstrual period, a woman can still get pregnant. So the risk of getting an abnormal baby is very high, babies with congenital abnormalities. So it's important to use contraception, whatever form of contraception. It's important to use it for at least 2 years after the last period, so we do not get unexpected pregnancy. Mood swings and sleep disorder. These are just basic things. We should use cool, dark, quiet room to sleep, use bedroom for sleep and sexual activities only. Don't just stay in your bedroom to be just lounging. It's always better get out of the bedroom, come back there to sleep. Because we get hot flashes, we need to use lightweight sleepwear so that we're not too hot at night. Avoid heavy evening meals because then the person is uncomfortable, reflux, and all of those kind of things which can affect sleep. Avoid alcohol, caffeine, nicotine, and chocolate. Many people say, oh, I drink my wine, it helps me to sleep. Yes, your wine will help you to start sleeping, but it will actually wake you up. People don't realize that. Alcohol wakes us up in the night. You may be able to get to sleep, but you will not be able to maintain sleep. So using alcohol to sleep is not a great idea. And then chocolates. Many people forget that chocolate is full of caffeine. So eating those late night chocolates is not the best. Exercise daily, but not too close to bedtime. It said that avoid exercise at least about a couple of hours before bedtime because exercise brings on the happy, let's get going hormone in our body. So if we do it too late at night, then it will affect our sleep. Whatever relaxation techniques that you like to use, whether it's music, whatever it is, use it to try and sleep. Then regular sleep schedule. Try and go to bed about same time every day and try and get up about same time every morning, even on weekends. That's very, very important. So hormone therapy. when I write it as HT, that's basically hormone therapy, which is estrogen, progesterone. They are not approved for treating mood swings or sleep disturbances. Somebody had talked about that in the question time. So we do not use hormone therapy to treat mood swings or sleep disturbances in an isolated case. If somebody comes to me and says, I'm perimenopausal, I'm having mood swings or I can't sleep, my first go-to will not be hormone therapy. Well, I will talk to the person about all those things that we had just discussed in the previous slide: relaxation, stress reduction techniques, counseling. There's a new kind of a psychotherapy that's been out in the last few years called the CBTI, Cognitive Behavioral Therapy for Insomnia. It's very, very new. Not a lot of psychologists are trained in it. So if somebody wants to go try, make sure that psychologist is actually trained in CBTI, not just CBT, because it's been found to be very, very good for poor sleep in menopausal women. Antidepressants and anti-anxieties are still the go-to for treating mood swings in menopausal women. So if somebody is depressed or anxious, it is not hormone therapy, it is an antidepressant or anti-anxiety, and there are lots of them out there. So many: fluoxetine, sertraline, a lot of names. Your primary care physician can choose which one that they feel that will be best. Then there's sleeping medications too that can be used, prescription sleeping medications. There is a caution, as we all know. A lot of sleeping medications are very, very addictive, and the body can start depending on them. That's one thing. Secondly, a lot of sleeping medications have now been found to be related to memory loss. So they can cause memory loss and they can predispose people to falls. So all of those we need to consider before we started taking sleeping medications. And if we have to, as much as possible, try not to take it every day so the body does not get used to it. Use only as absolutely needed. Okay. So talking about treatment for hot flashes, we'll just run through again. 75% of women report hot flashes perimenopausally. It was around the menopause time, and first 2 years resolves 3 to 5 years in most women, but maybe for lifetime, and more severe in smokers. This is next to weight gain. Hot flashes is the next common concerns by a lot of women. So first, the non-medicinal way of treating hot flashes: smoking cessation if the person is smoking, exercise, healthy weight, eating food that are high in antioxidants do help. Good hydration, drinking things that are cool to just cool our body. Makes sense, it's hot, so the body is hot, so we cool it down. Dressing in layers so that if we start feeling warm, we can take one layer off, especially for us in Canada, living in the winter time, maybe 2-3 layers, so you can take one layer off when those hot flashes come. Triggers: spicy food, caffeine, alcohol. We try as much as possible to avoid them so they don't trigger hot flashes frequently. So this is an area we had quite a few questions about: the complementary and alternative medicine. Studies and studies and studies have been done, and all of these products look like placebo. There's some of them soy products. There's so many of them out there. There are pills that are already made. Some people will say they're drinking more soy milk. Some people will take the pills. There are even also pills that they've actually extracted the little bit of estrogen in the soy product out and made it into capsules, but they haven't been shown to be to be great. In some people it may help, but it's not being consistent. Then there are traditional Chinese medicine that are out there for menopause use. Acupuncture, some people have said it helps them. We talked about black cohosh, cranberry, St. John's wort. St. John's wort, people use it for mood swings. Valerian root, people use it for poor sleep. But many of these things, it's not really helped. Somebody talked about evening primrose oil pills. Evening primrose oil pills are actually only been found to help a little bit with breast tenderness. It doesn't help at all with hormone, with menopause. So other over-the-counter medications, dietary supplements, vitamins, and things like that are out there, but they don't work. Some companies are selling progesterone online that people are buying to help them sleep. Please, 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 please do not do it. Do not do it. I will tell you the reason. Don't ever buy progesterone online to use. Melatonin. Melatonin is like the hormone that we secrete in our body. It may help with sleep, but when it's sleep disorder related to menopause, not that great. But it can help with change if you travel from somewhere to another place where there's a wide time difference. Melatonin may help you to kind of reset your sleep back. Other causes of insomnia, it may help a little, but with menopause related one, not so much. The hormone therapy. Hormone therapy, we can start off with using the contraceptives. Women who are still perimenopausal haven't yet done that 1 year celebration of no period can use oral contraceptives as their hormones. So if you're having hot flashes, or you're starting to get dryness, or you're having even the regular period that today you're bleeding for 5 days, next month you're bleeding for 20 days, we can use hormonal contraceptive form of pills, rings, or patch, and you continue that for 2 years after your period stops. People always will ask, how then do I know I'm in menopause if I'm using birth control pills? You will know because your period will stop. And then when your period stops, then we'll wait for 2 more years and then we can take you off of that. The only thing is if the woman is smoking, say no. 36 years old is the cutoff. If you're a smoker, you should not use any contraceptive after age 36. So that's the only big contraindication to that. Then when somebody is now in full menopause, estrogen is the only approved and gold standard treatment for hot flashes. So you can use other things if the woman has contraindication to hormones. But if there is no contraindication to hormones, number 1 treatment for hot flashes is estrogen. Estrogen only, we will only use it for someone who does not have a uterus. But if you have a uterus, you have to combine progesterone with your estrogen. Why? Because estrogen lays the bed in your uterus for the baby. So every time we go through the circle before we go into menopause, estrogen is that one that lays a nice cushion bed, always expecting a baby to come sleep in it every month. Then progesterone is the one that mows it off and say, okay, there's no baby here, let's clean up this bed. So what we say is estrogen is a grass fertilizer, progesterone is the mower. So if you have a uterus, we do not want to keep fertilizing that grass because that grass is going to grow to a point and become a cancerous grass. So you need the moa to constantly clean that grass out. But if you don't have a uterus, there is no worry. You can use only your estrogen alone, because it's your estrogen that you really do need for the hot flashes. Then I'm going to talk about bioidentical hormone. The word, I don't know if any of the women either online or here have heard bioidentical hormone, they're safer, they're better, they're safer, they're this, they're that. The word bioidentical hormone just basically means bio. Bio is like our body. It's biologically identical to our body. That is just what that word means. But when people say it in every day, when women talk about bioidentical hormone, they're actually talking about compounded bioidentical hormone. Compounded bioidentical hormone is made by your pharmacy, in Shoppers, in Safeway, in their little pharmacy. They get the powder, they add. They're the ones who actually make what they give you. Those are not regulated. Therefore, today, your pharmacy may give you, it's not because they want to harm you. It is because there is possibility of human error. Because when I weigh something, many of us know, if you go to your doctor's office every year for your height and weight, they're never the same. Because the nurse that is this tall looked at your height, she looked at it this way. It's an inch higher. The nurse that is this tall looks at your height, she looks at it this way, you are an inch taller, we are an inch shorter. So it's the same thing. When they're weighing those powder, it's not as accurate as when a company is making it in a big factory where robots are measuring it to the microscopic grain. So they're not, and they end up being so expensive. Bioidentical hormones can be given to you prescribed. So already made by whatever company, I don't want to mention because we're going to put this online. I don't want to mention any company, but big pharma companies make bioidentical hormone. They make it in form of cream. They make it in form of pills you can use. So if you're looking for bioidentical hormone, you can get it as a proper, well-made big pharma prescription. So don't get carried away when people say they're safer. The compounded ones are safer. That is the next thing. Whether it's bioidentical, whether it's not bioidentical, the safety is the same. Estrogen is estrogen. Progesterone is progesterone. So you don't need to spend so much. You don't need to get a pharmacy to make some things that only will last for a few hours, a few days, because it was locally compounded. So that is for that. So if anybody ever talks about bioidentical hormone, because you've attended the menopause class, ask them, oh, are you talking of compounded bioidentical hormone? Because that's what people are talking about when they talk of bioidentical hormone. Okay? So then the non-hormonal prescriptions that can be used for hot flashes: antidepressants, sleeping medication, gabapentin, clonidine, pregabalin. So these are non-hormonal prescriptions. These should only be used for hot flashes in women who either have absolute contraindication to hormones, or women who are 60 years or over. Okay, absolute contraindication. Somebody has breast cancer, uterine cancer, and the oncologist says, do not give them hormones. Then you cannot give them hormones. You have to find something in here to give to them. Somebody has a liver disease or some genetic disease and the specialist says, please do not give them estrogen, then you have to give them one of this. Otherwise, if the woman has no absolute medical contraindication, they can still go ahead and take their hormone. Somebody will ask me, oh, what if my mom had breast cancer? Mom having breast cancer is not a contraindication to the person using hormone, because the combination of estrogen and progesterone is the one that they found that it could increase the risk of breast cancer a little bit. And they don't even say it's not causing the breast cancer. It may just make the person show the symptoms earlier or get a little worse disease. And it's in just very, very little number of women. Whereas estrogen only actually decreases the risk of breast cancer. So people that say, oh, mom, auntie had breast cancer, so they're going to suffer it, you don't have to suffer it. Then I mentioned age 60. We generally discourage women at age 60 to stop hormones. The reason is that when they did the big Women Health Initiative study, they found out that after age 60, women who were still on hormone therapy had increased risk of heart disease, strokes, heart attack. So we commonly do recommend at about age 60 for women to go off their hormone therapy. Then the next question someone is going to ask me, should I just wake up one day and quit it cold turkey, or should I wean myself off? It's up to you. It doesn't matter. Whichever way you go, you're going to get hot flashes again. But this time around, they're going to be less intense and they're going to be shorter and they're going to quit quicker. So whether you quit it cold turkey or you wean down, you will probably still get some hot flashes, but it will stop quicker. Then some women will still say, I want to try it. I want to keep going after 60. If you come to me at age 65 again, I'm going to tell you stop. And the reason why I'm going to tell you stop again at age 65 is that heart disease here, then at age 65, if you're still on hormone, you increase your risk of dementia. Yes. So we commonly encourage people to stop at age 60. Does that mean there are no women who are 70 and still taking their hormones? There are. They just say, you know what, I'm ready, I will take it, but I do not want to suffer these hot flashes. So some women still will continue. So all of these antidepressants, gabapentin, as we know, gabapentin, we use it commonly for pain. It can be used for seizure disorder. It can be used for migraine. It also can help with hot flashes. Then Clonidine used to be a blood pressure medication. We don't really use it much for blood pressure, but we can use it. But all of this only mildly will reduce hot flashes, nothing as good as using hormone. Pregabalin, we use it for nerve pain. That also can be used, but all of these are like level 6 down from using hormones. Okay. Yeah. So sexual function and management. The next thing people come to talk about is pain with intercourse, no libido, not interested, and all of those. Several components to a woman's interest and function. There's biological, part of it, dryness, stimulation, is the partner not stimulating them right? Are there relationship issues? We talked about midlife, that's when most people get divorced, that's when there's all kinds of relational issues going on in marriages and relationships. Personal history, the person had some issues when they were younger, sexual abuse and things like that that are still affecting them. The context, we talked about families, parents may now be temporarily living at home. Is the context all right for partners to engage in sexual activity? Kids are older, some people are not really comfortable with playing with each other in front of their older kids, so some of those things may be there. Then negative expectations, sometimes because the person just did not enjoy the sex the other time. So how is it, how are they going to want to do it? Or because maybe partner commented on something, they're now sensitive, they don't feel comfortable continuing. So all of these components makes up a woman's sexual interest. We're not just like this go kind of humans. Unfortunately, we're not like our male counterpart. Too many things kind of get roped into our sexual interest and stimulation. Types of dysfunction in women: there's the reduced desire or just aversion, just not interested, or I don't feel like, it doesn't come to my mind. There's reduced arousal, it comes to mind, partner tried to encourage it, but you just don't have that feeling, you don't feel aroused doing it. Disorders of orgasm. Orgasm comes too quickly, or no, or not at all, or some people cannot achieve it. They are aroused, but they just cannot achieve orgasm, so they're really not satisfied at the end of it. Then pain and spasm in the vagina area. I mentioned about moisturizers and lubricants. So moisturizers, there are lots of them in the store. You do not need a prescription for moisturizers. Most moisturizers are once every 3-day use. So we have to, when we're not recording, if people want names, I can give names. But because we're recording and I'm a physician, I'm not supposed to mention too many names because it means that I'm supporting that company and it doesn't matter. So we can get moisturizer. So the difference between moisturizer is that the woman just puts that in themselves every 3 days. They do not have hormones in them, so you can use it for as long as you want. Lubricants are different. Lubricants are to be used during sexual intercourse when there is some form of penetration into the vagina. So it can be used during sexual intercourse or can be used with vibrators. So lubricants are different. Always buy water-based or silicone-based lubricants. Please do not use oil. Again, do not use anything that has oil. Vibrators, sexual intercourse, very, very encouraged because it increases your sensitivity. It stimulates the tissue of the vagina to continue to try and reproduce cells. So it's important. If we do not put anything in there, it will close up. You don't use it, you lose it. So, so it's important. Yes. So let's make sure that we don't deprive the male of their of something they like. Okay. Then prevention of STIs. It doesn't matter what age we are, we can still get sexually transmitted infections. So if it's not a regular partner, please remember to use your protection. It does not respect any age at all. Okay. So treatment of all these things we've talked about, the different female sexual disorders. The gold standard again for vaginal dryness is estrogen, vaginal estrogen. And the good news about this type of estrogen is, unlike the one I talked about earlier for hot flashes, vaginal estrogen can be used for life. You don't need to stop it at age 60 or 65. And the second good news is that only in very, 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 very rare kind of uterine cancer, vaginal estrogen can be used after breast cancer. It can be used in some even uterine cancer. So it's quite useful. So any woman comes to me, dryness, the first thing is vaginal estrogen. You can try moisturizers yourself. The thing about moisturizers, it will only moisturize. It will not really reproduce the lining of the vagina. You need the estrogen to help that lining to grow back. So that is the big thing, the advantage of vaginal estrogen over vaginal moisturizers alone. So it will treat the dryness, pain with intercourse. It may help with urinary incontinence, and it does help with recurrent bladder infection. So how it helps with urinary incontinence is that, just based on this diagram, this is the vagina, this is the urethra opening. When we don't have the support anymore, then it drops down. So the urethra opening, which is where pee comes out from, is open all the time. So in some women, that's why they're getting incontinence. And that's why infections tend to go in, because now you don't have that elasticity to keep the opening of the urethra closed all the time. So because of that, infection tends to go in. Plus, for urinary incontinence, because of the lack of estrogen and because we're losing collagen, the bottom of our bowl, which is the bottom of our pelvis, is not as grippy as it should be. It's kind of relaxed. So because it's relaxed, then your bladder sits on top of your pelvis and your pelvis tightens it before it becomes the tube that takes out the urine. When that tightening is loosened, what happens? We cough, we sneeze, pee comes out. So that is how estrogen can affect urinary incontinence and can cause recurrent bladder infection. And that is why vaginal estrogen does help in a lot of women. Then there's a pill that's called ospermifene. It's a tablet. It's not really commonly used. Truthfully, I've never really prescribed it, but it's there because it causes hot flashes. It will help the dryness, the vaginal dryness, then you compensate with more hot flashes. So many women are like, nah, I don't want it. So that's also available. Then other off-label medications that can help with arousal and orgasm disorders, it's those ones listed, piperacillin, bupropion, then testosterone, which is the only time that I will approve compounded hormone because we do not really have it done by the big pharma. Testosterone may help a little bit to increase the person's orgasm because if the person's arousal and libido. Then there is an injection that's still in the oven. They haven't baked it yet. There's also another pill called Ristela, which people can use. This is a supplement. This Ristela is a supplement, and you can just get it over the counter, and it's supposed to help some with arousal and orgasm. So these are all the medications. Truthfully, between me and you, are they really that great? They may help some people. They may not help some people. So I find that many times if people deal with the circumstantial things, it does help much more than even all this medication, whether it's relational issue, whether it's being open to talk to one's partner. Many women do not tell their partner what arouses them. We're being born to be shy. We're born to we're made to be passive, to be passive in sex. It should not be. Women need to let their partners know what stimulates you, what does not stimulate you. So all those need to be done to help with orgasm, with arousal, because we shouldn't always be just passive. It shouldn't be just about the man being satisfied. We are also sexual human beings, and we should enjoy sex. Pelvic floor muscle exercise, that also can help, especially in the area of orgasm. If the pelvic floor is stronger, it has been found that it will help with better orgasm, because then the muscles can tighten up better to achieve that. So there are also laser treatments. They're my fun toys, kind of, and my favorite kind of treatments. I do have them. And the reason is, when I got into all these menopause things, I ended up being the first physician in the whole of Western Canada to own a laser, which later other physicians got. So I was quite excited about it. I had to go to LA to get trained for it, and I stayed in the hotel, unfortunately, where Whitney Houston died. But yeah, but they made sure they had rearranged the numbers of the room so nobody will know the room she died in, because I wanted to go see. Yeah. So I like the lasers, because to me it was a sign that at least women are being considered. At least people are now looking, like farmers and equipment makers are looking beyond just our face. No, every laser was all designed to make women look beautiful. Nobody was thinking of what satisfies us. Yes, we like to look beautiful, but maybe I'm just being a bit feminist. It's everything about our face, our look is, a man just presenting us, this is my beautiful wife. It's about our face kind of thing. So for one person to think about something that the whole world isn't going to see, but we are going to feel happy about, that was my thing about laser. The advantages of the lasers that I have is they're safe. You don't have to be taking medications every day. They have very minimal side effects and minimal downtime when you're treated with it. But of course, because the new equipment in the market, the cost is still high. And many insurances aren't covering it, including our lovely healthcare in our province. They're still not covering them. So that is the big disadvantage. It is a cost for a lot of people. And the first laser I'm going to talk about is the BTL Emsella. It's an electromagnetic stimulation of the pelvic floor muscle to rehabilitate the weak pelvic floor and to help restore neuromuscular control of the bladder neck. So it's mainly used, it was brought into the market, used in the treatment of urinary incontinence. So any urinary incontinence that's being caused by the weakness in the pelvic floor, it's great for that. If other things are causing the urinary incontinence, like people having abnormal bladder, abnormal nerve issues, it will not treat those. Or some people that have full prolapse, I've seen women come to me who their bladder is completely prolapsed down. It's not going to help, because it's not going to take your bladder back up into the pelvis. It will tighten the pelvic floor, but if the bladder is already below the pelvic floor, it can't drag it up there anymore, unfortunately. It may improve orgasm because of its neuromuscular stimulation. It may treat painful sex, because people who have vaginismus, basically what happens when we doctors are examining them is the moment you touch what we call the introitus, which is the entrance of the vulva, the muscles just go like that into spasm. A lot of people who have it is as a result of possible childhood sexual abuse or things like that. So unfortunately, anything close there, the body just reacts by tightening up. So when they do this pelvic floor muscle exercise, it kind of helps the muscles to relearn to relax. So it may improve general sexual satisfaction because of better orgasm. Unlike the pelvic physio, which I do also recommend if that is what the person's insurance will pay for, pelvic physios are great. They also do close to what the Emsella will do. I usually put them in hierarchy. Your own self-pelvic floor muscle exercise is here, then pelvic physio is there, then Emsella is on top of them all in how good pelvic floor muscle contraction you will get. But for the Emsella chair, you don't need to take off your clothes. You just sit on it just with your full clothing. Pelvic floor physio, you have to be fully undressed below the waist for that. Contractions are more and greater intensity with Emsella than with any of the two exercises, like I said. But of course, individual response to the treatment always varies. The second laser, it's the MonaLisa Touch laser. That was the first laser. That's the one I talked about that I had to go train in the US for. This one, it's a hormone-free fast way of treating vaginal thinning and dryness. So basically, what it does is it does what the estrogen will do without you using the vaginal estrogen. So it will help to increase the blood flow. It will help to stimulate the thickening of the mucosa, and which will inversely, once there's increased blood flow and increased elasticity, there's more secretion of the normal vaginal discharge, and that will change the flora, the pH, and will decrease pain with sexual intercourse because now there is moisture in the vagina, and should improve the libido because then the person is no longer worried and scared of having sex because it's not painful. And same thing, some people respond very, very well. Some people, instead of 3 treatments, have ended up needing to do 5 treatments for them. So each person varies how their tissue responds. So general management of a urinary incontinence. There are 3 types of urinary incontinence. There is the stress urinary incontinence, which is I cough, I sneeze, I laugh, I pee my pants. The urgency urinary incontinence is I got to go and I got to go now. Is there anybody in the washroom? Get out, I need to go in. Then there is the mixed urinary incontinence, which is both of them occurring together. So those are the 3 main types of urinary incontinence. How do we treat them? We usually encourage people drink lots of water. But if you're having to wake up in the night to pee lots, then you want to stop drinking water by 7 p.m. at least 2 to 3 hours before bedtime. So you would have emptied your bladder as much, so it's not waking you up. We all know caffeine makes us pee because caffeine is a diuretic and a bladder irritant, so we want to avoid it. Regular bowel movement. Constipation does stretch our pelvic floor. So it's good for every woman to have regular bowel movement. Every time we go to the toilet and we're pushing and we're straining, this is what we're doing to our pelvic floor. We're stretching it, and it's an elastic. So imagine you stretching your elastic, what's going to happen? It's not going to go back, cinch back as time goes on. So regular bowel movement is important. Fiber, fiber, fiber. Urinating regularly. If we go too often, we're shrinking our bladder. The bladder is a very elastic organ. That is why if we catheterize somebody in the hospital for too long, sometimes we clamp them instead of just taking out their catheter, because you've already drained that bladder for so long, it's shrunken. So if we pee too often, we reduce the capacity of our bladder. Also, it's not advisable to keep urine for too long. So you've got to find a happy medium. Then if you're going to be doing your own pelvic floor exercises, if you don't want to visit the physio, you don't want to do the Emsella, you need to be doing 60 to 80 pelvic floor muscle exercises per day, about 10. And the good thing about pelvic floor muscle exercises, you could all be doing your pelvic floor muscle exercise as we've been sitting here all afternoon. So try, you can be anywhere in your office, you can be doing your dishes, and you can do your pelvic floor muscle exercises. So basically what you want to do, because people say, how do I do my Kegel? Please do not pee stop. For some people who have had kids here, they will tell you at the hospital when you're discharging you home, they'll say, oh, to get your pelvis back, when you get home, you pee, you stop, you pee, you stop. Please do not do it. That is very wrong. They used to teach us that it's wrong. To do your pelvic floor muscle exercise, imagine yourself that a fat wants to come out, you don't want it to come out. So you're going to hold it in, but do not stop breathing. So imagine you hold your bum hole in, you're still breathing, you're not pushing your abs until you can feel it tighten up to the front. So the key is don't stop breathing, because if you stop breathing, then you're not contracting your pelvic floor. So you're holding in a fat and you're still breathing with it, okay? So that is what your pelvic floor muscle tightening, so we can all try that ourselves, yeah, okay? And then control urges to urinate using pelvic floor tightening. You need to go, if you're having especially urgency incontinence, you need to go, tighten up about 5 to 10 times, and then breathe. Try and do something to distract yourself, so you're reteaching your bladder that it doesn't have to go now. So you can start a little bit and keep increasing that time in just about few minutes interval. Don't try to do it for too long and end up getting an accident. That won't be good. Medications. There are medications that we use for urinary incontinence. Oh, sorry, I didn't spell. I'm just noticing that my spelling up there is not right. I missed the C. So yeah, so medications, there are medications that we do prescribe for urinary incontinence. You can get pills from your doctor to help you. So another thing, it's not just aging. Many people get that and they're told, oh, it's age, just go home. No, you can get treatment for it. There are pessaries. You can go to the pessary clinic. There are pessaries that can be used to hold up the bladder, so that also will prevent urine from leaking. And then there are surgery to lift up the neck of the bladder to prevent people from having incontinence. So all of those treatments are available. Okay, so that's kind of brings us to the end of the general summary of the common thing.